This webinar is brought to you by Mumbai Hematology Group, and this session is supported by and sponsored by Sanofi. To introduce our session for the faculties for the first session, we have Dr. Sunil Bhatt, Director and Clinical Lead, Pediatric Hematology, Oncology and Blood and Marrow Transplant at Mazumdar Show Medical Center, Bangalore. Then we have Dr. Pawan Kumar Singh, Group Director, Hemato-Oncology and BMT, Yatharth Hospital, Greater Noida. Dr. Uday Kulkarni, Professor, Department of Hematology at Christian Medical College, Vellore, and Dr. Mallikarjun Kalashetty, Consultant Hemato-Oncology and BMT at Manipal Hospitals, Bangalore. The agenda for the first session is context setting by Dr. Pawan Kumar Singh from Noida. This will be followed by the lecture on tackling the challenges of inflammation and fibrosis in chronic GVHD by Dr. Sunil Bhatt from Bangalore, followed by your panel discussion, and Dr. Pawan Kumar Singh again from Noida will be moderating the event, and the panelists would be Dr. Sunil Bhatt from Bangalore, Dr. Uday Kulkarni from Vellore, and Dr. Mallikarjun Kalashetty from Bangalore. Hence, I invite first of all Dr. Pawan Kumar Singh, Noida, to please start this session. Dr. Pawan, you are the right?
Hello. Hi,
yes,
everyone. I'm Dr. Pawan.
Yeah.
I think I'm audible.
Yes, you're audible. Please go ahead.
Yeah. So thank you all the panelists and all the speakers who have joined us online. And it's a wonderful session. So when we do complication related, and one of that is the most important complication is chronic GVHD. So we have a very eminent speaker. So be taken by Dr. Subhat. He is of out over to
some problem in the connection. Dr. Sunil, but you can take over.
I'm guessing that I have to start, right?
Please go ahead. Please go ahead.
Okay, so first of all, good evening, everyone, and thank you, Mumbai Hematology Group, Dr. Amit and Dr. Agarwal, sir, for having this very important session and inviting us for this session. I am going to be talking for the next 20-25 minutes on the challenge of chronic graft versus host disease and what are the current strategies we have to address this, and some of the latest data on belmocidil. So this is a disclaimer. So I think we all need to know this before we start the presentation. Now we all know this is for just to start the conversation about this very important topic that acute and chronic GVHD, which used to be previously classified based on the duration of post-transplant at 100 days was typically kind of a watershed area, but now this has become irrelevant, and we have classic acute, classic chronic, and overlap syndrome based on the organs involved and the type of manifestation or type of phenotype the GVHD has. So it's no longer kind of dependent on the time frame post-transplant. As has been already been said, GVHD is a very important complication post-transplant. I look at this, in context of both related as well as unrelated donors. GVHD forms an important cause of mortality post-transplant, second only to the primary disease. And it may be a little different in Indian settings where infection probably a little bit more than GVHD, but nonetheless, an important cause for morbidity and mortality in post-transplant patients. Chronic GVHD is relatively commoner than we think. Around 30 to 70% of the patients will develop some sort of chronic GVHD, and out of them, 30 to 40% will develop a more severe form of chronic GVHD, which of course is a huge complication to tackle, especially long-term complication which comes with it. And very important is that a quarter of these patients will have a prior diagnosis of acute GVHD. And hence, when we look at the Risk factors, chronic GVHD, the previous acute GVHD is a very important risk factor. And, those who have acute GVHD will have a high risk of chronic GVHD. That's something we should need to keep in mind. And that has got important implication in the context of, treatment as well as prevention of chronic GVHD. However, there are other risk factors: female into male donor, older age recipient, peripheral blood transfusion, and also peripheral blood stem cell use, HLA disparity. More the mismatch, more the risk. And also, if there is not a use of T cell depletion strategy like ATG or PTCY or graft manipulation like T cell depletion, in those patients, there will be higher risk of developing chronic GVHD. Now, when we look at the pathophysiology of chronic GVHD, it of course has three important phases. The early inflammation is actually increase of pro-inflammatory T cells, which are usually Th1 and Th17, and of course, caused by tissue injury, and that tissue injury, manifests antigens to the immune cells, and which lead to early inflammation. Chronic inflammation is precipitated by or continued by increased pro-inflammatory T cells, Th17 and Th1, and also reduction in the T regulatory cells, which are, which have an important role, especially in prevention of acute and chronic GVH. And the last stage, or the third stage, the fibrotic development, which we always, are scared of, or is one of the most, morbid stage in the chronic GVHD development, and that is the tissue repair, which happens with fibrosis and continued chronic inflammation, and that leads to the severe and mostly irreversible phenotype of chronic GVHD. And this fibrosis, which happens as an end stage in the pathophysiology of chronic GVHD, can affect skin, mouth, joints, eyes, GI tract, esophagus, liver, and lungs. And that leads to life-threatening complications and significant morbidity, as mentioned earlier. And there's some of the pictures which we see day in and day out in our practice. Examples of skin, eye involvement, teeth and gum involvement, oral mucosal involvement, whether it's airway or upper GI involvement, and the most kind of difficult to manage and treat is the lung involvement and lung fibrosis, which happens as a consequence of chronic GVH. Now, what's very important also is patient impact of chronic GVHD on quality of life. As this is a long-term chronic complication which goes for months and years. The quality of life suffers and suffers in practically each and every domain when we look at the quality of life assessments. Whether it is functioning, whether it's emotional, psychological, in terms of general well-being, body pain, social functioning. All these domains are affected by chronic GVHD, and that's an important aspect of monitoring as well as management in the context of chronic GVH. Now, as mentioned earlier, the organ involvement in chronic GVH is a little different than what we see in acute GVH. The skin being the most common one, followed by mouth and eyes. And then we have GI and the visceral involvement, which is liver and lungs, and sometimes it can also affect upper GI and joint and fascia, being also important organs to be involved in the context of chronic GVH. It's a multi-system disorder, and multiple important organs are involved in the process. Now, just a brief on, how can this be prevented. One of the important aspects of prevention has been use of ATG. So ATG has been shown to reduce the incidence of both acute and chronic GVHD. And if you look at the chronic GVHD on the right hand side, use of acute GVHD does have impact on the incidence of chronic GVHD, and does improve the chronic GVHD incidence in the patients who get ATG as a use. Also, there's emerging data on the use of ATG even in haplotransplants where PTCY strategy has been used, and we are very aware of this very important paper, one from China, and also the paper from France, where they used ATG in conjunction with, in addition to PTCY, and this was the paper on AML, which came from use of low dose ATG, which was 4.5 milligram per kg, along with PTCY. And if you look at the acute as well as chronic GVHD rates, it was significantly lesser in the ATG group, and that was statistically significant as well. So that is, some brief about the burden of chronic GVHD and the risk factors, and how some of these risk factors can be kind of addressed by use of ATG in the pre-transplant conditioning phase. Now, what's the treatment landscape? The treatment of acute chronic GVHD has been revolving around systemic corticosteroids for a long, long time, and that still forms the first line of treatment with or without calcineurin inhibitors, and that's been well established. We know it's very effective treatment for them, but 70 of the patients will require a second line treatment, either because of the poor response to steroids, or steroid dependence, or uh, you know side effect profile of corticosteroids, which can be sometimes limiting because of intolerance or poor response to the second line therapies. So it is definitely a difficult disease to treat, and sometimes multiple agents and multiple lines of treatments are required. Now, what are the key molecular pathways in chronic GVHD? And if we understand that, then we can understand some of the new medications which have come up, and some of the treatment modalities which have been employed in the recent past. And one of them is ROC pathway. It's a very important pathway which is involved in inflammatory as well as fibrotic components of chronic GVHD, which is important because, as I said earlier, in the pathophysiology, both inflammation and fibrosis, which are two important stages in the process of chronic GVHD, and this is something which ROC pathways mediate. Same thing is the JAK pathway as well, and JAK pathways are involved in the development, proliferation, and activation of various immune cell types, which are involved in the chronic GVHD processes, and that's how JAK inhibition would actually help by down regulating those pathways. BTK is a pathway which predominantly exists in B cell trafficking, and it helps in B cell trafficking, chemotaxis, and adhesion, and it also kind of using the BTK inhibitor would downregulate those B cell mediated pathways, which is also important contributor for chronic GVHD development in addition to the T cells. And IL-2 is a cytokine which is essential for T cell development and activity. And it plays an important role in controlling immune-mediated responses, and hence, as T cell impaired function is characteristic of chronic GVHD, so use of IL-2 does, impact that and leads to, T cell development and expansion, and that can control your chronic GVHD as well. So if you put them, across in a table, as I said earlier, on first line treatment is usually systemic steroids, and dexamethasone, prednisolone are kind of the most commonly used ones. And we also there's always a second agent along with these, whether CNI, cyclophosphamide, tacrolimus, or sirolimus, or mycophenolate along with this. And some of the few mentions have been of ruxolitinib as well as the first line agent in the recent guidelines. A second-line agent has been predominantly based on ruxolitinib, and also in the recent times, ibrutinib and imatinib for its antifibrotic activities. And we can have some other agents which I mentioned here, especially B-cell agents like rituximab, also as a second-line agent if the first-line agent has kind of not worked or they have been intolerant to that. And third line, there is no definitive protocol for third line agents, and there have been multiple options, combinations being used in different settings. And what has been used is ECP, also predominantly either the second or third line agent in some of these patients who would require an additional treatment, not responding to the earlier lines of treatment. So a couple of slides on the recent, available molecules which have shown promising result. One of them is ibrutinib, and ibrutinib is a BTK inhibitor, which was showed in the pathophysiology a couple of slides ago. There is a phase 2 clinical trial using ibrutinib in patients who had chronic GVHD covering more than 25% of the body surface area, and it was used in this study for about 42 patients. And if we look at this, the response rates were quite good. It was in the range of 60+%, and that is also so it's a very important agent which can be tried in a chronic steroid refractory setting. REACH 3 study, which studied ruxolitinib in patients more than 12 years of age, and there was REACH 5, which was for patients for less than 12 years of age, and we enrolled on REACH 5 trial from our center. That is also published now in recently Lancet Hematology, and this was a little earlier than that, which was REACH 3 study for more than 12 years of age, and this was patients with moderate and severe chronic GVHD where it was used with, either you were unsuccessful to reduce prednisolone for the treatment of chronic GVHD, or they were resistant to chronic, steroids. Here, there was a randomization which was done between ruxolitinib plus and steroids plus minus CNIs, and compared with the best available treatment option, which was used by those centers. And there was also an option of crossover study after week 24 assessment in this randomized trial. And what they looked at this in the study was that ruxolitinib group had better responses as compared to the other arm, and that actually reflected both in overall response rates, as well as if you look at the chronic GVHD free survival was better in Rux as compared to the best available treatment option, and hence it has become one of the second line agents also in the use of chronic GVHD treatment. Now, coming to the last bit of my discussion today is on belmocidil. And belmocidil, as mentioned earlier, it is a ROCK2 inhibitor. And ROCK2, as I said earlier, has got very important mechanism of one. It leads to correction of the immune dysfunction, immune imbalance in the chronic GVHD as a first stage. As I said earlier, is inflammation. That inflammation is because of increase in Th17, Th1 cells and reduction in T regulatory cells. And this kind of corrects that imbalance, and it downregulates T17 cells and increase the T regulatory cells, and hence has got a anti-inflammatory properties in that context. It also has got an antifibrotic property and antifibrotic action, and that again is a very important mechanism of action for this ROCK inhibitor, and that is, as I said earlier on, is the last stage of the chronic GVHD pathophysiology, and it makes it very important as well because this is the only agent we know at this point of time, in addition to imatinib, which can improve your fibrosis and also reverse fibrosis, which can be, as earlier, very morbid and have high mortality as a consequence of that. So ROCK is a downstream for major profibrotic mediators, and it leads to fibrosis and fiber formation, and it also regulates the transcription of profibrotic genes in the context of chronic GVHD, and hence inhibitor of this ROCK will help to downregulate all these processes and lead to reduced fibrosis and also reversal of fibrosis, which is an important terminal event in chronic GVHD. Now, when you look at the what is available data with the ROCK inhibitor, there are two important landmark studies which were done. One was 208, and the other one was 213. And the first one was on patients more than 18 years of age, and then they extended it to patients more than 12 years of age. In the first study, there were 3 dosage forms which were tried: 200 once a day, 200 twice a day, and 400 once a day. And the next study, which is the Rockstar study, which is 213, had 2 doses, which is 200 once a day and 200 twice a day. And if you look at the first study, which is 208, it was seen that all the 3 dosages, whether it was 400, 200 once, 200 twice, the 200 ones actually were a little superior than 400. I mean, not that was significant, but 200 once or 200 twice was good enough. And the overall response rates in this whole study was about 63%. In the response of the belmocidil, which was quite good, and that kind of led to the second study, which is the Rockstar, which is the pivotal study on belmocidil, and there are 2 arms. One was 200 milligram once a day, 200 milligram twice a day, which was taken from the previous study to identify whether there's any difference between the 2 arms and the larger patient group, and this was for more than 12 years of age who had active graft versus host disease, 2 to 5 lines of prior treatment, and these patients who warranted a systemic treatment. They also stratified these patients based on prior ibrutinib use, yes or no, and also severe GVHD, yes or no. And that's we'll discuss that a little later on. And they looked at the safety of this drug and also the response rates of this drug in these 2 arms. So what was seen is that 74% of the patients did have a response, which was the primary endpoint. So almost 3/4 of the patients did have a response, and that 200 milligram once a day, 200 milligram twice a day actually did not have any difference in the outcome. The two arms actually behaved similarly. And if you look at this subgroup, which is 200 milligram once a day, and look at the responses based in the different groups, whether it was early or severe acute chronic GVHD, response rates were again good. Whether it was three more than 3 lines of treatment received before, more than 4 organ involved at the baseline, refractory to the last systemic therapy, prior ibrutinib use, prior ruxolitinib use, all the groups of patients, subgroup patients did have response rates in the range of 70-odd%, and that was quite reassuring that irrespective of the organ involvement, irrespective of the prior treatment, majority of the patients did respond to this, and 300 milligram was, as I said, equivalent to 200 milligram twice a day. And this is again the response rates in the same study based on different organ systems. And if we could look at the skin, eyes, mouth, joint, and fascia, were the ones where the responses were the maximum, but the visceral organs, which was liver or lungs, the response rates were, of course, less than the skin or joint and fascia involvement. Most of the patients, had responses started from 4 to 8 weeks, and after the responses were actually quite maintained, those who responded, and 94 of the patients' responses were observed by week 24. So most of the patients started responding by 4 to 8 weeks, and then some of the patients did respond a little later on also, and by 24 weeks, almost 94% who had responded to belmosudil. This is again, the sustenance of response and failure-free survival to belmosudil, and that's kind of shown here that responses were also sustained in a good proportion of patients. This is a secondary endpoint, which is overall survival, and overall survival, if you see, was at 2 years for about 85%, and that's quite reassuring for this group of patients, and some of them as well, severe and refractory to the prior treatments, and response rate at overall survivals of 85-90% at the follow-up of 2 years. One important thing which I mentioned earlier was quality of life, and this Rockstar study did also evaluate the quality of life in these patients after the treatment. And what was seen in that, almost 60% of the patients did, report more than 7% point reduction in the quality of life scoring with belmosudil, and so that was a good kind of and that was irrespective of responders and non-responders. Both the groups, of course, improved quality of life, but of course more pronounced in the responders than the non-responders. What's one of the important aim of these second and third line treatments in chronic GVHD is to enable us to have dose reduction in corticosteroids. We know the corticosteroid use for a long term, as well as CNI use for the long term, has got its own set of problems and complications, whether it is weight gain, obesity, hypertension, poor bone health, infection risk, and others. And that's why, long-term steroid as well as a CNI use is one of the problems in chronic GVHD treatment, even if they're responding to this treatment. So one of the aims of the second, third line treatment is also to enable us to help in dose reduction in these two treatment modalities. And what happened in this Rockstar study was that 50% of the patients did have reduction in the steroid doses, and 21 21 patients, which 27% of them did have discontinuation of calcium of steroids. And same thing happened with calcium inhibitor also. 52% patient had reduction in the CNI dose, and 28% patient we could discontinue calcium inhibitor on this study. And that was an important kind of secondary endpoint as well, and almost the steroid reduction dose was happen in a good proportion of patients who are on this study. So to conclude this rockstar study in both these studies, of course, that the it was well tolerated in the treatment. Only one patient had a fatal outcome, which was multi organ failure, and probably not related to this drug, but it happened on this study. There were also some other side effects, which included mainly infections, asthenia, diarrhea, cough, edema, hemorrhage. But these are all, most of them related to the chronic GVHD itself rather than the treatment. And less than 4% of the patients had developed cytopenias, and there were no CME infection reactivations in this study. Only one had CME reactivation in this whole study. And permanent discontinuation of the treatment happened in a very small number of patients. Almost was 3 to 4% patients who the drug had to be permanently discontinued for adverse reactions. So very well tolerated drug, especially in this very fragile population, and most of the patient could continue this drug. And as I said, most of the side effects were not related to this drug, and cytopenias and CMEs were very less. Now, if you look at the current guideline of the use of belmosudil, it's a new drug, but if you look at the EBMT update in 2024, it does mention that in patients with steroid-refractory chronic GVHD, belmosudil is a potential therapeutic option, and that's based on the encouraging results which have come in randomized trials, which we just showed you in the previous, and hence it can be considered, especially the patients who have a high infection risk and especially who have a risk of cytopenias. This is a drug which can be considered in the use of chronic GVHD. When we compare the belmosudil with other available treatment options in chronic GVHD space, best available treatment, ruxolitinib and ibrutinib. These are the two newer kind of agents in chronic GVHD space. If we look at those, belmosudil does have a quite favorable profile in the terms of overall response rates, in the terms of symptom score improvement, which is more of quality of life. So quality of life improvement is kind of maximum reported with this drug, and more and as I said, important is that reduction in the dose of steroids and calcium inhibitors could be achieved in a majority of the patients. Over 64% which had dose reduction, and 20-30% patients had completely discontinuation of the steroids or CNIs as a part of this. And very small number of patients in this study had discontinuation of the drug, which is quite high, especially in ibrutinib and ruxolitinib, because of the side effect profile, especially cytopenias with ruxolitinib, and also infection risks which happen with ibrutinib. So the continuation of the drug has been kind of highest with this agent because of the safety profile it carries with it. So to conclude, what we discussed in this section is that chronic GVHD, of course, is an immune-mediated process, which is mediated by chronic inflammation and fibrosis, and the traditional therapies which are used in the treatment of this condition, especially steroids, are actually significant morbidity and mortality. And hence a new range and a novel range of therapeutic modalities have been developed, which we discussed. These therapies, the idea is to help us to come down on steroid as well as calcium use, to prevent the long-term morbidity with these drugs, and also help, if possible, to control and reverse fibrosis if at all possible, and also control inflammation. And that's how some of these drugs are work. And we showed you one example today where there's data in both fibrosis as well as inflammation because of mechanism of action. Before I conclude, I just want to leave it with a case. It's not my case. It's been shared by one of our friends because we don't have access to belmosudil at this point of time in India. It was available very briefly for some compassionate use, and we have very few patients in India have used belmosudil in our patients on compassionate based use. But this is borrowed from one of our friends who had this patient, 18-year-old, referred to them for extensive chronic GVHD. And this patient at the time of presentation had, skin thickening, scleroderma, fasciitis, skin breakdown, ulceration at various points. And it was covering more than 80% of the skin. And there's some of the pictures of the patient with very extensive chronic GVHD. There was also other complication of chronic GVHD and its treatment, which happens from the treatment, as I said, steroids and CNIs, which are combined with the in the GVHD treatment. Muscle wasting, osteoporosis, growth restriction, rectal infections were one of some other associations of this patient, and he was referred for ECP to this friend, and had prior line infections as well as ICU admissions as a part of his treatment. This patient, in the history, actually, he was a beta thalassemia patient, was transplanted in India, actually, in 2012, with a fully matched mother. Myeloablative conditioning was used, and PBSE, collection was used. PBSE donor was used, and this patient had acute GVHD. And then at 6 months of change, it started developing these chronic GVHD changes, and they traveled back, and before COVID was treated in Thailand, actually, with IVIG rituximab and given ruxolitinib as well. There was no response, and then was shifted to ECP. 12 sessions were given. Then COVID struck. They went back, and then back to, and Turkey had 34 sessions of ECP and ibrutinib. But had to stop due to financial reason and some other reasons, so they couldn't continue for longer than that, and then moved back to to this to the referral place which we presented now, and has got a huge concerns in because of the GVHD and its treatment. This is the medication list, which is quite extensive. We all know in a chronic GVHD setting. At that point of time, it was on cerulose, ibrutinib, and steroid low dose for the management of chronic GVHD, and some other drugs which we go along with the chronic GVHD management. So he was not given any vaccinations yet because of his ongoing immunosuppression and chronic GVHD. And the plan actually was, the referral was to have ECP again started. But the problem in the past had been central line infections, thrombosis, which can still be a problem. He also needs a full assessment in the context of pulmonary function tests, DEXA scans, look at the bone, hormonal scans to look at his bone health as well as other hormones. He also probably needs some vaccinations to be started, especially, and this is a question for all of us. What else can we do? So he's been referred for ECP, and he will require all this evaluation to have other support mechanisms in place to control, to help with some other comorbidities he's having as a consequence of long-term disease and chronic GVHD. So belmosudil was considered for this child because he's more than 18 years of age now, and based on the data which we saw, and the treating physician actually decided to have ECP and belmosudil together. And this patient actually went to this treatment, which is belmosudil and ECP, was started almost a year ago. And what has been noticed is that this patient has improved, although he had some infection episodes in between, but has improved. And families still continue with the treatment with a good response to this drug. And this is the prescribing information for this drug. And I think we all can have a look at it in our leisure time. And that's what I wanted to talk to you. And thank you very much for this session. And I close my session here, and we can discuss a few other things in our panel discussion. Over to you, Dr. Amit.
Thank you, Dr. Sunil, for a fantastic lecture. It's always worth listening to you. And I now request all our discussants to please put the raising sign so that we can start our question answer session with Dr. Sunil Bhatt. Yeah. So, Dr. Ramesh, you have a question? You're muted, Dr. Ramesh.
Good evening, sir. So, with the availability of belmosudil, like where do you want to place it, sir? Like with ruxolitinib, we have seen cytopenias, especially in patients who are having CME infections, and on ganciclovir who are having pancytopenia, especially with thrombocytopenia. It's difficult to give ruxolitinib many a times. Like with the availability of belmosudil, like shall we consider as a steroid sparing agent at the like as a second line in, agent itself, or like in resistant cases only?
So if you, that's a very good observation and question as well, because as we know, use of some other agents which have been discussed here does come with their own limitations, especially with the drug you mentioned, cytopenia is an important side effect. However, cytopenias we see more commonly and more profoundly with acute GVHD treatment, and less commonly and less profoundly with chronic GVHD treatment. But nevertheless, yes, it is a concern, and it can happen in a significant proportion of patients, both cytopenias and viral reactivations as well. And I don't know how many of you have noticed, tuberculosis is coming as our own problem with use of some of these agents, which is the activation of tuberculosis, especially in older and elderly population. So that advantage seems to be here with belmosudil. So it does have advantage in the safety profile, both in the context of infection reactivation, also in the context of how much immune suppression it does, and also in the context of cytopenia. So all the three advantages seem to be there. Now the question is whether to use the second line or the third line is a little gray. I will tell you why, because the label is for two lines, failure of two lines of treatment. Now the question is, how do you define the two lines of treatment? Someone has received steroids and CNI, whether that's considered as second line, two lines of treatment, or someone has already received, and then you added a third agent like MMF, and that's considered as two lines of treatment. To my understanding, from the trial purposes, it depends on what they have been already on. For example, a patient was already on just one single dose prednisolone, and then you added a CNI after that, that becomes two lines of treatment. But if someone is already on steroids plus CNI, already on for prophylaxis, then you add a third agent, which is MMF, and that will become second line of treatment, right? So the definitions are, little bit, I would say, not vague, but, trial contexts are a little different, and the real world will be different. I would actually, if this data comes to be true in real world as well. See, we don't have a lot of data yet. It's all in trials, and it's all in a limited number of patients. But if this data is true in real world, I would, I'm really excited to see this drug to be used earlier, earlier as in second line context, because of the advantage over the safety and what we just discussed. So yes, I don't know what the Indian regulator is going to give them the label for. We'll have to follow that from the regulator's point of view, but it will be exciting to use this drug if it is, I would say, economically viable to use earlier on in the second line context. And of course, it will help us to reduce the use of CNI and corticosteroids, which we want to do as a sparing agent. Thank you.
Okay. Thank you.
Thank you, Dr. Ramesh. Anybody has any other question? So, well, in that case, should we start with the panel discussion? Let me share the screen again. So, with this fantastic lecture, we have again a panel discussion now, and this will be moderated by Dr. Pawan Kumar Singh from Noida. And to call upon the panelists, we have Dr. Sunil Bhatt from Bangalore, Dr. Uday Kulkarni from Vellore, and Dr. Mallikarjun Kalashetty from Bangalore. So, Dr. Pawan Kumar Singh, please go ahead.
Yeah. Thank you, Dr. Amit. And so we have had just now we had wonderful lecture by Dr. Sunil. He discussed about the overview and the treatment strategies of chronic GVHD. So we'll have this panel discussion, and I welcome all the panelists and Dr. Sunil also. So first thing I want to means this question I want to put to Dr. Sunil. Do you feel in our scenario, means our part of the world, in India particularly, if you see, do you really feel any challenges related to management of chronic GVHD, especially in the diagnostic part?
So challenges are numerous, but if I tell you from the diagnosis point of view, I think it's underdiagnosed. That's my observation, especially the limited chronic GVHD and the limited organ involvement is very underdiagnosed. And the best examples of that are IGVHD, for example. The best examples are GI GVHD, chronic GVHD. I mean. So I think we are underdiagnosing, and there are reasons for that. One is that the follow-ups are a problem. I think most of the times, they would go back from the treatment centers and do not have very strict follow-up coming back. Second is the amount of time we spend with these patients when they come back is limited, with the workload we have. So there's not dedicated. We don't. Most of us do not have dedicated GVHD clinics where you take time to assess them, analyze them. And the second is, also, the teamwork which is required for a chronic GVHD patient. Access to an ophthalmologist, endocrinologist, a GI, pulmonologist, access and doing in a teamwork is also not very well established. So I think diagnostic challenges are mainly in identification, early identification, teamwork and involvement of other specialties. Pulmonary function tests, what we should be doing are not done that regularly. And the third challenge is that sometimes if you need to have a diagnosis of not in the context of much in the skin and eyes, which are easily identified, but also in the context of, you want to look at a visceral involvement or lung involvement, capacity to do biopsies, and analyzing those biopsies is also kind of challenging. So these are some of the diagnostic challenges we have. Of course, there are many more, so I think we can discuss them eventually. Thank you. I think Pawan is dropped off. I can't see him on this system.
So just wait for him to join back again.
I think
Anything
completely
you want to
agree
add,
with Dr.
Uday?
Sunil.
Yeah.
Yeah, I think so. I completely agree. I think our best chance while dealing with chronic GVHD is to pick it up early, and especially with GVHD, like the lung GVHD, especially when you see chronic lung GVHD, many of the times when you pick it up later, it becomes very distressing, and reversing that becomes very challenging. So we have started doing regular screening day 90 onwards, using spirometry and lung volumes to pick up this GVHD earlier, because many of the times you may not have GVHD involving other organs. So we have put up a screening process for lung GVHD. Routinely, all patients who will be transplant day 90 onwards go for the lung screening with the pulmonology.
So, Dr. Uday, just one thing. Where do you place biopsy or the histology in terms of diagnosing chronic GVHD? Whether it is your diagnosis is mainly based on clinical in all the cases, or where do you means place histology as a diagnostic part workup for chronic GVHD?
For most parts, we would go clinically. There are certain situations wherein, if the lesions are very atypical, that time, some of the times we offer skin biopsy for diagnosis of chronic skin GVHD, but it's generally a clinical diagnosis. Most of the clinical features are very evident and classically described with chronic GVHD, where even for the lung, if there is evident lung GVHD, sometimes, we have seen situations where one can confuse it with infection. That's the time when bronch followed by TBLB might be done. But by the time that happens, we have generally lost the situation. So our best bet is to pick it up early, where patients are not really gone to a stage where they are requiring oxygen support and all. But I think we have once in a while we have seen such situations where patients have been on long-term oxygen therapy because of the chronic lung GVHD. So, but I mean, that's where you would probably, in that situation where you're not sure whether it's an infection or GVHD, we would offer a biopsy.
Yeah. And about so basically, if particularly musculoskeletal GVHD, if we talk about, so I think it is mainly based on clinical. So how do you come across, or do you see how frequent is it in your practice? You see,
As Dr. Sunil Bhatt also alluded to, it will be around 40 to 50% of our patients will develop chronic GVHD, especially now that we are doing more of alternate donor transplants. And I'm not sure whether with the use of PTCY, the problem with PTCY in our setting is there are a lot of data from the Western world showing that PTCY to be used even in match donor setting and match unrelated donor. I think the infection risk, we are always worried about the first 100 days infections, and consistently the engraftment being delayed, waiting for engraftment for day 17, 18, and the increased risk of bacterial infection is always a challenge. So
we still stick to cyclosporin methotrexate, with which we do see about 40 to 50% of our patients developing chronic GVHD.
Okay. Thank you, Dr. Uday. So next question, I want to ask Dr. Mallikarjun. Is he there? So, Dr. Mallikarjun, yeah, thanks. Welcome. So, where do a lot of transplant centers are coming up in India. Plus, we have some new centers also. They are coming up. So, where do you? Because you see, in the long run, if we see, if the number of transplants increases, so similarly, the chronic GVHD infect rates will also increase. So, where do you means what do you want to say to the our young hematology colleagues also, that so how to pick it early, how to intervene based on, because most of the time we are treating based on clinical scenario. So, what your point or your take on this?
Yeah. So I think both previous speakers have elucidated very clearly. Essentially, there are certain high-risk population where we know the risk of GVHD is very high in terms of HLA disparity, gender mismatch, elderly age group of transplant based on the donor source of transplant, and then disease that we use. So those are the patient subgroup that we have to be very careful. And in terms of chronic GVHD, there are certain situations where one has to be, so for example, isolated liver derangement. You were asking whether we have to do a biopsy in such scenarios where it's not very typical of GVHD. Then perhaps one should try and do the biopsy before adding medications for the graft versus host disease. And in terms of, it is a challenge for everyday clinician to kind of risk stratify, score the organs, and then follow them up. However, one has to try and do that. So I think those are the challenge. And also other important things are when patients are on GVHD treatment, one must make sure that the infections are screened for, that they're on adequate antimicrobial prophylaxis, look for hypogammaglobulinemia, make sure they are given intravenous immunoglobulin. So I think those are the challenges that one has to be careful about.
Yeah. So, and in your just your means your personal take on this, what strategies do you usually incorporate in terms of preventing chronic GVHD?
One is so we try and
So, in all categories of transplant, if I may ask, like for matched sibling donor, marriage unrelated donor, and haploidentical transplants.
Yeah, so I think we try and get PTCY in most haplotransplants, number one, and then make sure MMF and TAC are there, and then we look at the levels of the drug very carefully and closely, and titrate the dose if necessary. We also have tried to use PTCY in matched sibling donor, not in a lot of patients, but we have found that useful even in matched sibling donor transplant. We try and give some kind of serotherapy in matched unrelated donor transplants. And then again, so I think it is very important to look at the cyclosporin level, tacrolimus level very closely, and then titrate the dose, look at the liver and kidney functions, and make sure that is adequately looked at. Those are some of the things that I think are important early on in transplant.
Yeah. Thank you, Dr. Mallikarjun. So, next, the same question I want to ask Dr. Sunil. Dr. Sunil, in your practice, means what kind of strategy do you apply for prevention of chronic GVHD?
So see, prevention is very important, and prevention of GVHD starts actually pre-transplant. So I think we need to assess the risk of GVHD pre-transplant. That depends on various things: disease you're treating, the donor type, the matching, what conditioning you're using. So we, being a pediatrician, so I still stick to bone marrow as a predominant source of stem cells, and that's important, very important as well. So we don't see chronic GVHDs more than 10-15%. Maybe that's one of the reasons for that. We tend to use serotherapy now practically in all the patients. So all the non-malignant patients will have serotherapy, whether it's related, unrelated donor, or even haplo donor. The patients who are malignant, we were not using serotherapy till recently, but with this data emerging of low dose serotherapy, we have started using that even in a match setting. So that hopefully will replicate into lesser GVHD, but we don't have good enough numbers and follow-ups for those patients where we have used low dose ATG in malignant setting. But non-malignant setting, we have been using forever serotherapy. Second is for haplos, we do both the strategies, and we do depletion without depletion. And in experience, with depletion, the GVHD rates are extremely low, both acute and chronic. Chronic is less than 2 to 3%. But in PTCYs, we do still see GVHDs, both acute and chronic. And I don't know whether the use of ATG in that group, which I just showed a little bit of data on, is going to help, how it's going to come with the cost of poor immune reconstitution post-transplant, and that will replicate into higher viral reactivation infection. That's something to look at in our context. And then post-transplant, as I showed the data, and in unrelated donor setting, I always try to avoid older donors and female donors. If I have to choose between a haplotransplant and a mud donor where there's a female, a multiparous female, or even a male which is older than 45, 50 years of age, I'll probably choose a haplo donor over a mud donor, even if there's a 10 by 10 mesh donor, because the GVH rates are quite significant in that group. Now, coming to post-transplant strategies, as has mentioned by Dr. Malikan, it's very important to have good your CNI levels, and the CNI levels, there's a good data to suggest that CNI levels on day zero the graft goes in has to be therapeutic, and that has got implications in the both acute and chronic GVHD. And also, as I said earlier on, acute GVHD is the biggest risk factor for chronic GVHD. So to deal with acute GVHD effectively is very important, and also very important is to have a acute GVHD management, kind of for a longer time term than just resolution and then stopping it. So I think that the slower you go, the better it is, because that may have impact on the chronic GVHD. Good therapeutic levels, and last but not the least, which Dr. Uday also highlighted, is to have a very strict follow up and identification of chronic GVHD early, especially the organs which are, tricky organs, lung, GI, and eyes. These are the tricky organs for chronic GVHD, and there needs to be an early suspicion, a multi-team effort to identify them early so that we can deal with them early. So these are some of the things which can be done or which we do. Thank you.
Dr. Pawan.
Yeah, sorry, just I got disconnected. So next to Dr. Uday, since you are also from high volumes centers, so means if we want to manage chronic GVHD, so what is your management strategy? So means as a second line, if patient is not responding to steroid, or then we have to add on second line agent, because we all know that first line is always the systemic steroids, and then after that, when it comes to the second line, sir, what is your management strategy, and does it depend on the type of organ, or which agent you prefer in a particular organ, or is there any just same for all types of organ involvement? So, Dr. Uday.
Practically, if resources are there, we would give ruxolitinib as a second line after the steroids have, patient is not responding. So there is a progression after 2 weeks of steroids or no response. In another 3 to 4 weeks, we would add on ruxolitinib. If resources are limited, we use MMF and sirolimus very often. Sirolimus is a very, is an excellent drug for controlling chronic GVHD. Imatinib also works well for fibrosis. So we use tyrosine kinase inhibitor imatinib in musculoskeletal GVHD. We have access to ECP, but ECP costs are way over the roof. So that becomes very extremely challenging. Once in a while, we have used it for patients with especially the lung GVHD, and we have seen encouraging outcomes. So, that's the general protocol that we would follow if patients are not responding to steroids.
And where would you place ibrutinib?
Yeah, I think ibrutinib is also is a good option, but we don't have much experience of using it, because practically we would either use ruxolitinib in patients who are affording, or we would go with MMF, sirolimus. Even for that matter, the imatinib works quite well for fibrosis. That's also a good option.
Okay, so you are using at what dose? Imatinib, low dose, or it's a standard dose what we use in CML?
Yeah, we would start off, depending on the tolerability. If they don't have thrombocytopenia, we start with 200 and go up on the dosing. So that it's generally well tolerated.
So just now we had present. Thank you, Dr. Uday. So next is to Dr. Mallikarjun. So just now we had lecture by Dr. Sunil. So this new drug, that is ROCK2 inhibitor. So uh, theoretically, if we see that yes, this drug has, as far as the mechanism of action is concerned, and the in terms of reducing the inflammation and fibrosis, so where would you like to place the role of this belumosudil?
Yeah, thank you, Dr. Pawan. I think Dr. Sunil has indeed very elegantly presented the topic, and then it is very appealing, more so in chronic graft-versus-host disease. However, I have no individual experience. It appears as though it is actually targeting the heart of the matter of chronic GVHD and is not very myelosuppressive. And 200 mg once a day is indeed easy to administer. So I think it would be something that would be used earlier and perhaps longer, but I have no individual experience really.
So yeah, so by looking at the mechanism of action, the prevention of fibrosis, which is the pathogenesis of
Yeah.
this disease, I think Dr. Sunil has gone much detail into the data about that. So I think we can ask again, Dr. Sunil. So where do you want to place the role of, means when would you like to use in your chronic refractory chronic GVHD patients? So Dr. Sunil.
So see, I think there was question already asked about it, and I did briefly mention that the label is for 2 prior lines treatment. That's a label indication for this drug. I don't know what the Indian regulator label is going to be, so I think we'll have to wait and watch for that label in India. But having said that, I think in the real time, in real world, the data first of all is limited in real world, and if the data which has been shown in trials, and that is true in the real world, I think it's going to be a fascinating drug, and it's gonna be used probably more frontline as in inverted commas in comparison to other available options, which are rixalutinib, ibrutinib, and ECP. I think it has got a role to play in 2 circumstances. One is when the steroid refractoriness is there. And the second is also when you're steroid dependent or you're not able to get down on the steroid dose to counter the and have a steroid sparing agent. In both the contexts, I think it's going to be used, and it's probably is going to find its way as a second line agent in both these scenarios. But we go back to the mole point, and that is how convenient is it's going to be used. And I think the convenience of ease of administration is there, which is in comparison to ECP is very good, because ECP, as Dr. Uday already mentioned, we had about 200 ECP procedures in our center. But to be honest with you, we have never been able to sustain ECPs in chronic GVHD the way we wanted to. Acute, we have somehow been able to do it, but in chronic GVHD, we never have been able to sustain the way it has to be done. And that's, in fact, in more than 200 ECPs done already, but it's not been that effective in the chronic GVHD setting for the ease of doing it and the cost involved. So ease of administration is there. The safety profile is there. The third challenge which is going to be addressed is going to be the cost. If it's going to be in the sweet spot to be used, and because see, these treatments are long term. These are treatments for years together. If you see the REACH 5 study, which I was enrolling into, we enrolled those patients on the trial for 3 years. The treatment was for 3 years. In fact, more than 3 years, 39 months. And there was still an option of continuation after that. So these are long-term treatments. Cost is going to play a huge role in our setting. But if that is not the case, if we take cost out of it, it's a very exciting drug. As a second line, we would probably use it. Thank you.
Yeah, when we see particularly in lung GVHD, so there the efficacy or the effectiveness of this drug was not that great. So means suppose isolated lung GVHD. So in that situation, I think this drug would not be a good option compared to others like ruxolitinib or maybe ibrutinib.
I have a comment.
So
I don't know what's the experience of other people. All the patients we have lost in chronic GVHD space have been lung GVHDs, actually. Okay.
yeah, exactly. This is
Absolutely.
very valid point, because the mortality, particularly if we see, those are like other organ involvement, it is like morbidity. So lung GVHD, when it comes, it is basically the mortality is
And
it can lead
and,
to.
and my thought process on that is, which I just briefly mentioned, is that once lung GVHD is set in and you have a fibrotic phase, I think see the mechanism of action, even if it's a fibrosis reversal, that works very well in other organs. But in lung, the alveolar damage happens. There's a parenchymal damage. Even if you reverse the fibrosis, the damage has been permanent. It's like COPD. It's like chronic cigarette smoking. Whatever you do later on. So I think the poor response in lung with whatever treatment you give them is because of the stage these patients are already in. When you diagnose a lung GVHD, the game is already over actually. So identification of lung GVHD is always late, and even with reversal of pathophysiology or control of pathophysiology, most of the times, you don't succeed, and that's, I think, the main point. I feel this drug could be good with them as well, but if it's diagnosed very early, and hence the identification with pulmonary function tests and good follow-ups are very important. That's a challenge which we have in pediatrics, which are our PFTs are not good. We cannot interpret PFTs in smaller children. They cannot do it properly. So that's an additional problem we have with lungs. But adults, that probably is not that much of a problem, but I think should be part of our ongoing assessment. So I think the lungs, there's a pinch of salt there. Any drug you look for chronic GVHD, they don't work very good for lungs, and that's probably the reason. Thank you.
Yeah. So, Dr. Uday, so what is your means at your center? What is your strategy of managing lung GVHD once it is set in?
Yeah, so I mean, we had, as Dr. Sunil Bhatt also said, that we've seen quite a bit of morbidity and mortality also in when the lung GVHD becomes severe, and when we identified it, generally we have lost the game. So we instituted practice of monitoring, screening these patients. So screening all transplants from day 90 onwards. So that's an ongoing effort. And if there are any abnormalities, then the standard FAM protocol is started. And they also, there's a good crosstalk between the pulmonology team and the hematology team. And we try to increase the immunosuppression, and we will not reduce the immunosuppression if there is any abnormality or there is a dip in the lung function. So that's what we are trying to do. But I mean, we are still, far from understanding this completely. But I think, prevention seems to be our best chance rather than treating it. Picking it up early and, instituting some mechanisms to uh, delay its progression.
Yeah, I think thank you, Dr. Uday. So I think we had this wonderful panel discussion. So now I would just like to thank all the panelists for having this wonderful panel discussion. And I hand over the organizer, Dr. Amit.
Thank you, Dr. Pavan,
Thank you.
for wonderfully moderating the entire session. And that was a wonderful discussion. And now we have 10 minutes of time. Kalpesh, should we start with the next one? You have still 10 more minutes left.
International speaker yet to join, sir.
Yet to join. So
So
we
you may
can,
continue the discussion, sir.
if you may, please go ahead, Dr. Sunil. If you
No, I
want to.
just wanted to ask everyone, one of the challenges is monitoring chronic GVHD. So, uh, we had
Yeah,
this
this part actually, yeah,
challenge with the Reach 5, where the assessment of chronic GVHD monitoring was so elaborate, and it could be done because on a clinical trial, a number of patients were not that many. But how do you manage this in day-to-day practice? I had made a little abbreviated form of that NIH scoring system. But what does everyone else do? In their
so
busy OPD. So that's one discussion point. The second is that have you been able to successfully have chronic GHD clinics separate from the normal BMT clinics? Has anyone been able to do that successfully? We have not been able to do it successfully.
no, I think Dr. Sunil, you have this made this point a very valid point. See, in my practice, what I used to do is I have this app. I think you may be knowing, or other panelists may also be knowing that GVSD app. So that has we try to calculate. So once the patient comes and we are suspecting both, it is for both acute and chronic GVSD. So we try depending on that. It takes 1 to 2 minutes. So depending on the symptoms, like which organ is involved. So it hardly takes 1 minute, and then we used to just calculate it and just mention in our prescription when the patient is from OPD. For IPD, we just put it in the notes what stage it is there and which organ involvement is there. So that usually helpful in managing these patients, and also follow up also there, because when it comes to one person seeing the same patient every time, But in high volume centers where it is like whole team is involved, then it is not possible. At your center also, you can recognize that you may not be saying the same doctor may not be seeing the same patient every time. So assessment is very important, and documentation of that stage is also very important. So when it comes to the monitoring of the patient, so yes, that will be really a means privilege to have GVSD, especially chronic GVSD clinic. So if any center is able to do that, that will be means hats off to them. So if they are doing that, but yes, that will be the future of GVSD care, what I would say.
Uday, you have been
Maybe
able
other
to
panelists can
separate
convert.
GVHD clinic?
No, no, sir. I think, but that's the way forward. I think we need to reach there. But currently, we've put in the GVHD sheet, chronic GVHD sheet with all the assessment, organ assessment. But the implementation of that is far from ideal. So I think I agree. There is
Yeah,
a
but this app is there. App is good. At least
yeah.
we can at least every time when we are seeing, we should document that.
One more thing is, supportive care. I think we focus quite a lot on treatment. I got a patient recently referred with chronic extensive GVH of a child transplanted elsewhere, and the child has had multiple lines of treatment, rightly so, and it was not like there was any mismanagement. The lines of treatment that child has got multiple lines, but appropriate. But the only problem was, is the general supportive care, a bad bed sore, poor nutrition, less than third percentile nutrition, weight for the age, and multiple vitamin, mineral deficiencies. So I think one of the important aspects also in both acute and chronic, of course, is the supportive care, and we need to have a good structure in place where the nutrition, infections, physiotherapies, emotional support, all of that is taken care of, not only for the child, also for the family, because they get tired by the time. So that aspect of care is also important, because these are long-term chronic issues, and we may not be able to get. If you see all the data on all the drugs we have discussed, the CR rates are very, very less. These are all partial responses. So this disease is actually there for years, and sometimes mostly for ever. I think we need to have those aspects to build in our care system as well. And that's sometimes, very important than, of course, treating them with the drugs and changing the lines of treatment. So that was just our observation.
Well, so thank you so much. Our international speaker has joined now, Dr. Vikas Gupta. Welcome, Dr. Vikas Gupta. And I thank all our panelists, as well as a special thanks to Dr. Sunil Gupta, and very special thanks to Dr. Pavan Kumar for moderating this event. Thank you so much. We'll move on to the second session. Let me share the screen again. So next we have our guest speaker for the day, Dr. Vikas Gupta from Toronto, Canada. And he's going to lecture us on myelofibrosis, fine-tuning the treatment with ruxolitinib. This session is brought to you by Novartis, Unipath, Lucien and Nirvin Life Sciences, and very well managed by Perfect Square. I thank Team Novartis, Unipath, Lucien and Nirvin, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Vikas Gupta from Toronto, Canada. All our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing the Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Let me introduce our discussants for the day, and here displayed in alphabetical order. Just to name them, we have Dr. Aditi Harsh Thanki from Rajkot, Dr. Aditya Jandial from New Chandigarh, Dr. Aishwarya Raj from Ahmedabad, Dr. Akanksha Garg from Ahmedabad, Dr. Anshul Gupta from Lucknow, Dr. Arun VA from Mumbai, Dr. Govind Patel from Jodhpur, Dr. Hasmukh Bala from Surat, Dr. KK Radhika from Hyderabad, Dr. M. Gopinathan from Lucknow, Dr. Mahadev Swami from Goa, Dr. Narendra Agrawal from New Delhi, Colonel Dr. P. Suresh from Delhi, Dr. Ramesh B. from New Delhi, Dr. Sandeep Nimani from Miraj, Dr. Sarita Rani Jaishwal from Delhi, and Dr. Thilagavati Venkateshan from Chennai, as well as Dr. Upendra Sharma from Jaipur. Just to introduce our guest speaker for the day, we have Dr. Vikas Gupta from Toronto, Canada. Dr. Vikas Gupta works in multidisciplinary clinical lead in leukemia is a professor and Barbara Becker Chair in Leukemia at Princess Margaret Cancer Center, Toronto, Canada. He is working in the multidisciplinary clinical lead of the leukemia program at Princess Margaret Cancer Center and is also director of the Elizabeth and Tony Comper MPN program. He holds the Barbara Becker Chair in Leukemia and Related Disorders at the University Health Network. His clinical and research activities are focused on developing novel transplant and non-transplant based treatment strategies for patients with myeloproliferative neoplasms. He is a founding member and past president of Canadian MPN Group. The MPN Group at the Princess Margaret acts as a national resource for the care of complex patients with MPN. The MPN program offers short and long-term skills building opportunities for fellowship training, training of community hematologists and oncologists, as well as other healthcare providers. Today he is with us and is going to lecture us on myelofibrosis, fine-tuning the treatment with ruxolitinib. Well, thank you so much. I stop over here. Over to you, sir.
First of all, thank you, Dr. Agarwal, and the organizing committee for this meeting. I understand it's a little bit late in India and for a Saturday evening, and so my talk is going to be more like I would not necessarily going to lecture you, but perhaps it's a learning opportunity for share my experience, but also sort of learn from your experience. So over next 45 minutes or so, I'm going to talk about fine-tuning some of the available treatment for myelofibrosis, and perhaps in the end we will have ample opportunity for approximately 15-20 minutes to sort of discuss any of the issues concerning you. I'm very keen to learn from you guys that how do you manage myelofibrosis in your setting, and hopefully if it will be a mutual learning opportunities for us. These are my disclosure. I work a lot of novel drugs, and my association with these companies primarily sort of doing clinical trials, but sometimes I advise them on the drug development for their portfolio. So if you look at the natural history of myeloproliferative neoplasm, and there are three main classical MPNs, essential thrombocythemia. I'm just having a little difficulty in moving this screen. No, don't want to leave the meeting. Okay, I think this is good. Can you guys see my slides properly?
Yes, sir. We can see very well. Please go ahead, sir.
Okay. So the natural history of the myeloproliferative neoplasm, very familiar to you guys. The patients, there are three classical myeloproliferative neoplasm: essential thrombocythemia, polycythemia vera, and myelofibrosis, which can present as primary myelofibrosis, or patients with ET and PV can go on to progress myelofibrosis in the natural history of the disease. And all three classical MPNs have a risk of developing into secondary acute myeloid leukemia, also known as MPN blast phase, and which is usually a pretty poor prognostic disease, and pretty much sort of end stage of MPN, and the outcome of patients with secondary AML from previous MPN continues to remain poor, despite sort of several new approaches in that area. Okay, my slides are not moving. Okay, let me see. Okay. So my objectives of my talk today is understand the selection of therapy option for myelofibrosis, and I'm going to present few cases from my clinical practice. How to optimize the use of ruxolitinib in clinical practice, and what to do when ruxolitinib is no longer working. I will briefly talk about new therapies on horizon. For deliberately, I haven't put a lot of details about the new therapies, but I'm happy to answer any question in the end, sort of, as this audience may have. So first, looking at the symptoms of myelofibrosis. Myelofibrosis patient present with variety of symptoms. No two patient with myelofibrosis is same. So patient symptoms can be grouped into sort of, anemia categories such as shortness of breath, fatigue, etc. Symptom related to splenomegaly, fullness in the stomach, pain in the spleen area, dragging sensation, difficulty in walking, constitutional symptoms such as symptoms which are associated with increased inflammatory cytokines in the blood. And these symptoms usually are fever, night sweats, weight loss. Uh, and these symptoms can be sort of, grouped into three categories: anemia, symptomatic splenomegaly, constitutional symptom. Some patient have symptom in all three domains. Some patient have sort of, symptoms more prominent in one domain. And in addition to these three type of symptoms, patient can have variety of other symptom: bone pain, pruritus, thrombotic complication, bleeding complication, increased risk of infectious complications. So I was reviewing what data has been sort of, published from India on myelofibrosis. And apart from some sort of, case series, there is a limited data available from India. So, and that sort of, I'm saying right in the beginning that my presentation includes data which is from the studies which are primarily done from in North America, Western European countries. So, and published data also has some bias towards high income countries. So this is a study which we done in our group. One of our previous fellow, Aniket Banker, who has joined as a faculty member now. So what we did was we looked at, it's a very simple study. We looked at in the province of Ontario, we have a central database called IC. ES. And this database houses all the information about any patient who has gone through the system, how many, because we have a one payer system where everybody is covered through sort of, a universal healthcare program. So they have data on everybody who has gone through, how many times the person has visited doctor, how many emergency rooms they've been admitted, how much time they spent in hospital. So we kind of like use that data to understand what kind of healthcare resources patients with myeloproliferative neoplasm use. And we kind of like created a control cohort which was matched for age, sex, income, and neighborhood sort of, residential address. And then we try to sort of, see what will be the resources control population will be using and what would be the resources patients with MPN will be using. So not a surprise that patients with among the MPN patients, patients with myelofibrosis use more resources. They have more hospitalization, number of visits to emergency room, but there are still significant resources used by ET and PV patient. And compared to matched control, ET and PV patient had 2 to 3 time increased use of healthcare resource utilization, and myelofibrosis approximately 5 times more use in comparison to their age and gender matched control. Now, what has sort of, really revolutionized the field of myeloproliferative neoplasm was the discovery of JAK2 mutation. JAK2 mutation was described in 2004, and shortly after JAK2 mutation, MPL mutation was described. And then it took another sort of, another 10 years to describe the other main mutation which was present in JAK2 negative patient, which is we understand now is CALR mutation, which is present in 25 to 30% of patients with ET or myelofibrosis. And patients with polycythemia vera primarily have JAK2 mutation. A small proportion of patients who are JAK2 negative with polycythemia vera, which will have a mutation in another hotspot called exon 12 in JAK2, which is very similar to JAK2 mutation. So 90% of patients with myelofibrosis, we are going to find one of these three driver mutation, JAK2, MPL, or CALR, and 10% of patients with myelofibrosis will not have one of these driver mutation, and those patients are called triple negative patient. Irrespective of the mutation, all these three mutation can lead to dysregulation of the JAK-STAT pathway. So one central message is going to be that current JAK inhibitor, they work both on JAK2 positive and JAK2 negative patient, because all these three mutation ultimately led to dysregulated JAK-STAT pathway, and current JAK inhibitor are not mutation specific. I'm going to discuss a bit more detail in the later part of my presentation. So in addition to these three mutations, there has been a variety of other myeloid mutation described in patients with myelofibrosis. And our group started doing next generation sequencing or all new referrals with myeloproliferative neoplasm in 2015. So we looked at sort of, what are the clinical utility of these mutation in MPN, and I'm going to briefly discuss that. So over the number of years, several other mutations, which are not necessarily specific to MPN, these mutations can also be seen in MDS, acute myeloid leukemia. And these mutations, some of these mutations are considered have significant impact on prognosis and are considered high molecular risk or high risk mutation. So in various scores, currently 5 mutations have been included. They are ASXL1, EZH2, IDH1, SRSF2, and U2AF1. You have to be careful about U2AF1. It's a mutation on hotspot Q157, which is prognostic. There is another mutation, hotspot mutation in Q34. It doesn't have prognostic value. So when you look at U2F1, you have to be sort of, also mindful that you're looking at the right mutation. So these 5 mutations are considered high molecular risk in today's date, but there is increasing data that there are other mutation which may be sort of, included in this risk score. And one of those mutation is TP53. And there is a significant amount of literature now in myelofibrosis that it's a mutation with low frequency in the chronic phase and is only present in about sort of, 2 to 3% of patients with PVET MPN who are in the chronic phase, but this mutation increases in about 25% of the patient when disease progress to blast phase. And in addition, there is a sort of, RAS mutation and FET mutation also sort of, described to have poor prognosis, but these mutations have not been integrated into the molecular risk score. And then I just want to mention that among the driver mutation, CALR mutation has mainly two types of mutation, type 1 and type 2. Type 1 is a 52 two base pair deletion mutation, and type 1 is a 52 base pair deletion, and type 2 is a 5 base pair insertion. And the type 1 CALR mutation has a, a better impact on the prognosis of myelofibrosis patient, where type 2 has a similar sort of, impact on the outcome of the myelofibrosis. Now, over the number of years, last, I would say 25 years, we have made a lot of progress in understanding of the natural history of myelofibrosis. So 25 years back, we were mainly use very simple score, like Lille score had two component, hemoglobin, white blood cell count. So based on two component, patient used to be divided into high, intermediate, low risk categories. This scoring system further evolved into then 3 scores, which were International Prognostic Score, IPSS, Dynamic IPSS, and DIPS Plus. they were described sort of, very rapidly over a period of 3 years. And these are the scores which are quite widely used in patients with myelofibrosis, either clinical trial or routine clinical practice. In addition, there have been scores which also include integrate histopathology, grade of fibrosis, and molecular information. And these scores also have been started, people have started using these scores also in particularly in making decision for transplant, etc. in these patients. So there are so many scores in myelofibrosis described. Sometimes people feel sort of, what score should I use? And my approach is that try to use sort of, whatever access to information or testing you have. And I understand genetic testing may not be available to everybody, or patient may not be able to afford it. So if you don't have anything, I think still TIPS is a very good score and still serves the purpose very well. It's a clinical score based on age, anemia, white blood cell count, presence of constitutional symptom, presence of blast in the peripheral blood. So if you have a CBC count of the patient and you've taken a good history, it's a score which sort of, is still very, very good score. But if you have more information, cytogenetics and NGS type of data, then you can sort of, think about using a MIP 70 or MIP 70 plus version 2.0, one of these scores, which has more molecular data. Now, it is important to understand sometimes people use scoring system to decide whether a patient should be candidate for JAK inhibitor therapy or not. Scoring systems were mainly devised to understand the prognosis of the disease, so you can make a decision that which patient are appropriate candidate for transplantation. So I would say the treatment for myelofibrosis, if I have to put a one line to the treatment of myelofibrosis is sort of, um, a treatment is risk stratified treatment based on the risk of the patient, like patients with intermediate to or high risk disease, whereas uh, treatment of non-transplant treatments are symptom dependent. So if patient is asymptomatic and has a higher risk score, don't treat them. But if patient has symptom of splenomegaly or constitutional symptom, even has low risk score, you may want to treat it. So I'm going to and just to mention about, I was looking at are there any guidelines from India, and I came across this guideline for transplant indication in India. So pretty much sort of, in line with what is done in the West. In West, probably sort of, you would transplant patient up to the age 70 years, but majority of patient, I mean, these recommendations are pretty consistent with what we do. We do transplants in sort of, patient under 50, 55 with myeloablative transplant, and above 55 usually sort of, will consider reduced intensity transplantation. I just want to sort of, mention about what has sort of, happening about utilization of various donors, because some of this may be applicable and in Indian setting. So traditionally, when the field evolved, sort of, most of the transplant were done for using matched sibling donor. Then the wave came that matched unrelated donor transplant also were sort of, increasingly being used. And lately, the CIBMTR data shows that there is a increasing trend of using haplotransplant, which were at one stage people were not doing that. There may be some engraftment issue with the haplotransplant, but I think with the post-transplant cyclophosphamide, that barrier has been overcome, and there is increasing use of haplotransplant in myelofibrosis patient, and this may be applicable to some patients sort of, in Indian setting, who don't have a family donors and have a lower chance of finding a unrelated donor on the donor registries. Um, and this is a slide that there has been a gradual improvement in the transplant outcomes over the last decade. Slide on the left is a study we did with the CIBMTR. And if you see that there is a significant gap in the outcome of HLA sibling transplant versus unrelated donor transplant, but if you have a partially or mismatched donor transplant, then that gap is they not have very good outcomes. And that study was published in almost like more than 10 years back. And then a more recent study, which Dr. Tanya Jan led from Johns Hopkins, showed that this gap which we observed in the previous study of CIBMTR seemed to be closing with better supportive care, with the use of post-transplant cyclophosphamide. We are overcoming some of the barriers with some of the things which are considered barrier for transplantation in myelofibrosis in the past. So next 20-25 minutes or so, I'm going to mainly talk about the non-transplant therapy. There are 4 JAK inhibitors which are approved by FDA: ruxolitinib, fedratinib, pacritinib, and momelotinib. My understanding is ruxolitinib is the only JAK inhibitor which is approved in India at present. But I'm happy to learn whether you guys do use other JAK inhibitors in clinical practice, and if you do, then how do you procure them? So this is a study we recently published. This study was done in high income and middle income countries. And this study was done in the era after the approval of JAK inhibitor. And in this study, there are people from 14 countries participate, and we looked at the real world data, that what is the prescribing pattern of use of various treatments which are being used after we took patient from any country after the approval date of ruxolitinib in that country. So when we looked at this data, the most common first-line drug used in patients with myelofibrosis is ruxolitinib, used in 42% of the patient. A significant number of patients are on hydroxyurea, 33%. And then ruxolitinib was the most commonly used drug as a first line and even subsequent lines. And this graph, Sankey diagram, tells you how these patients moving from ruxolitinib to next line of treatment. One thing which we learned from this study was that the use of transplant in first year after the diagnosis was very low. It was about 3 to 4% in the first 52 weeks of um, when patients started first line treatment. So very few patients are getting transplant as a first line treatment. So I'm going to go through some studies, case studies from my clinic. I'm going to talk about this first case, which is a 66-year-old female who was incidentally during a routine checkup found to have incidental finding of anemia and leukocytosis, and then subsequently underwent further workup, including molecular studies, bone marrow examination, etc. And then the diagnosis was confirmed as JAK2 mutation positive primary myelofibrosis with grade 2 fibrosis. At presenting white cell CBC had shown hemoglobin of 99, leukocytosis with white blood cell count of 13, platelet count of 154, and she had 1.2% blast in the peripheral blood. She had spleen, which is palpable by 7 centimeter below the costal margin, but there is no constitutional or splenomegaly related symptom. She's very well. And according to IPSS, she is above 65, has anemia, and has presence of blast in the peripheral blood. She will meet the criteria for high risk. And according to the DIP scoring system, she meets the criteria for intermediate to risk disease. Now, This patient, some people will say that, okay, patient is intermediate to risk disease, patient has splenomegaly, start this patient on JAK inhibitor. And this is something we try to sort of, teach our referral base, our trainees, that these are not the patient you would benefit from JAK inhibitor. This patient does not have any constitutional symptom, fever, night sweats, weight loss. This patient doesn't have any splenomegaly symptom. So I followed this patient for almost like 8, 9 years, and this patient continued to remain well. Only thing changed was hemoglobin gradually sort of, moved from 99 to 94 over 5 years. So every patient is different. And so the point I'm trying to make is, do not get into the trap of intermediate to risk disease, start Jacobin. No, that's not. Understand the trajectory of the disease in your patient and then make the decision that this patient has something which will benefit from giving Jacobin. Otherwise, don't sort of, blindly use Jacobin in these patients. So on the other hand, there's this second case where patient is 52-year-old male who presented many years back with CALR mutation ET and subsequently developed, dragging sensation in the abdomen and drenching night sweats, meaning the patient was having significant symptom burden related to splenomegaly as well as constitutional symptom, and further sort of, repeat bone marrow confirmed the diagnosis of progression of disease from ET to myelofibrosis, and these were blood work. So hemoglobin 128, white blood cell count 10, platelet count 109, and no blast in the blood, and spleen was palpable by 9 centimeters. So this patient has intermediate 1 risk disease. Now, I would argue that this is a kind of a patient you want to start on Jakavi. No, the risk may be intermediate 1, but this is a patient who could potentially sort of, benefit from treatment with Jakavi. And I am perfectly fine to start somebody who has a lower risk with myelofibrosis to start on Jakavi than blindly starting any patient with sort of, higher risk disease with Jakavi. So important thing to understand is understand the trajectory of the disease and start the treatment with some goal that does patient has a symptom which can be sort of, helped with Jakavi. Talking about just going through the sort of, various treatments. So this is um, a fairly early days when the clinical trials start for ruxolitinib, that sometime we do see patient with myelofibrosis with very advanced disease, and treatment with ruxolitinib does lead to rapid reduction of splenomegaly. Now in this slide you will also note that not only splenomegaly improves, but there is a cachexia type of picture as shown by muscle wasting in the intercostal space on the left picture, and on the right side you'll see that the intercostal spaces start filling up, mean that patient's nutritional status starts sort of improving. Now, the approval for ruxolitinib was based on 2 pivotal trials where ruxolitinib was compared to placebo in Comfort 1 trial, and ruxolitinib was compared to best available treatment in Comfort 2 trial. And at that time, majority of patients who were in best available treatment did receive hydroxyurea as first-line treatment. And as I showed you that over the last 10 to 15 years, the treatment patterns have changed, and now ruxolitinib is the first-line treatment for majority of patients with myelofibrosis. So this is a summary slide for the pivotal trial done with the 4 approved JAK inhibitor, where Comfort 1 ruxolitinib versus placebo, Jakarta trial for fedratinib against placebo, and Persist trial for pacritinib, where pacritinib versus best available treatment. Best available treatment was not JAK inhibitor in this trial. And the only trial which has compared one JAK inhibitor to other JAK inhibitor head-to-head is Simplify 1 trial, where momelotinib was compared to ruxolitinib in a sort of 1:1 randomization. So if you see that all 4 JAK inhibitors lead to some degree of sort of spleen volume reduction, And again, similar thing is seen in the symptom reduction that, all JAK inhibitor sort of, lead to some form of symptom reduction. But JAK inhibitor therapy is not like BCR-ABL inhibitor or CML patient. It's not a considered curative therapy. Patients are living with disease. There's a disease persistent. This does not lead to significant reduction in the MPN driver mutation. So there's a limited anticlonal activity. There is lack of improvement, or in some patient actually leads to worsening of cytopenia. There is a risk of atypical infection. JAK inhibitor therapy does not reduce the risk of leukemic transformation. It doesn't work forever, and there are significant rates of discontinuation. In our hands, sort of, median time, average time patient benefits from ruxolitinib therapy is 2 years, although I do have some patient who have sort of, it's a small proportion of patients who have gone with ruxolitinib for more than 5 years, about sort of, roughly about 10% of the patient. And then there's no convincing effect on the bone marrow fibrosis. So one thing which is sort of, I get lots of emails from people all around the world with sort of, what do we do, like ruxolitinib therapy and tuberculosis. And there is we did a very recent literature search. Again, there is very limited data, only sort of, small case series. And given that ruxolitinib does impair T cell immunity, there is a risk of reactivation of latent TB infection. In my practice, if patient is from endemic area for tuberculosis, we screen those patients with one of the TB tests. We used to do tuberculin sort of, skin test, but we kind of moved from doing skin test to now sort of, quantiferon test, which is kind of easily can be done. I'm sorry. Sorry for this. And now ruxolitinib, again, these are the guidelines which were published by an Italian group. And basically, they do caution that ruxolitinib should not be administered to patient with uncontrolled TB. And if you are using isoniazid prophylaxis, be mindful of the liver toxicity when you are combining with the isoniazid and ruxolitinib. Ruxolitinib is feasible to do if TB infection is controlled, but patient should be carefully monitored for signs and symptoms of recurrent infection. And efficacy of sort of, latent TB infection management with antituberculous medication with ruxolitinib has not been, I did not come across any literature in the on a recent sort of, literature search. So this is something which is sort of, we need to learn more. I sort of, I would be, I'm happy to learn from what you guys do in your clinical practice, because perhaps you guys see a lot of sort of, patients in this setting. So now, one thing about ruxolitinib is there are few sort of, tricks of the trade, and these are not necessarily based on clinical evidence, but I'm going to sort of, present some of my approach. How do I select starting dose of ruxolitinib in myelofibrosis? And we sort of, these are the post hoc data from um, uh, uh, Comfort One trial, where in Comfort One trial, the dosing of ruxolitinib was based on baseline platelet count. So if patient had baseline platelet count more than 200, those patient was starting dose was 20 milligram twice daily. If patient had baseline platelet count, which was between 100 and 200, starting dose was 15 milligram twice daily. So we just we looked at Comfort One data, and we looked at ask a very simple question that people who started with 15 milligram twice daily, what was their dose when they were at 24 weeks post treatment? So as you see from this graph that A lot of patients who started with 15 milligram twice daily, had a dose reduction to 10 milligram twice daily or a 5 milligram twice daily, and only 15 to 20, 15% of the patient were on 15 milligram twice daily or higher doses. So 15%, about 15 milligram twice daily, and 10%. So 1/4 of the patient were on 15 milligram twice daily or higher dose. In comparison, patients who were given 20 milligram BID dose, almost like 2/3 of the patient were able to continue on that dose, and then about 25% of the patient led dose reduction. So this is important to understand that patients